Hi, Michael. מייקל, אני תכף מעביר לך את ההוסט ותשתלט על הכל, בסדר? תעשה את הכל, האינטרודקשן. יאללה, כך.
Hello.
Hi, how are you?
Big sis.
Hi, how are you?
Great. So great to have you. Rise and shine. 6 there now.
It's 5:57. Yes.
Oh, wow. So huge thanks for doing this. Yoav, are you here?
Yeah.
Sorry.
I'm here.
So why don't you connect? I'd like to introduce you to Tanya, my senior fellow.
Tanya, thank you so much for joining us today. You're in Australia right now?
I am in Australia right now. That's right.
So Tanya's a megastar. She basically took over Greg Maloney's practice.
So why aren't you upside down if you're in Australia?
I'm actually hanging from the roof.
So Tanya is just one of the most amazing people I've ever met, honestly. Amazing human being, amazing surgeon, amazing clinician. She taught me so much during the fellowship. I was just honestly privileged to work together with her. Yoav is my partner in crime in our dry eye clinic in Herzliya. He's the vice chair of the Department of Ophthalmology at the Rabin Medical Center, which is probably, I don't want to get in trouble with anybody else on the line, but probably the biggest cornea service and one of the biggest ophthalmology departments in Israel. Yeah, so
in the galaxy, actually.
In the galaxy, yeah. He's definitely an opinion leader, a key opinion leader in Israel regarding ocular surface disease. Like all the nasty OCPs and all that, they all get sent to him. And I'd also like to introduce you to Margarita, who's on the line with us right now.
No.
I think you met briefly via email.
Yes, absolutely. I'm excited.
So Margarita's a rising star in Israel, and she's definitely a huge academic, very talented academician, and writes amazingly. Like literally, she'll throw out an idea, and the next day there's a paper. So like, we also have Itamar here, Itamar Abel, which works with us in the dry eye clinic. Itamar, are you there?
Yes.
So Itamar is also definitely one of our rising stars. So Itamar, Tanya, my senior co-fellow.
Hello.
Nice to meet you.
The best fellow University of Toronto cornea ever had.
Not true. Not true at all.
So Tanya, Israelis are classically late, so we will wait a few, like 5 minutes, just to let everyone else in, and then I'll give you the official introduction.
Okay.
We'll have a diverse audience, residents, senior faculty, general ophthalmologists, cornea specialists, retina specialists, all. So we'll be quite diverse. So it should be interesting. Usually we'll just ask them if they have any questions not to interrupt and to put them in the chat box. And before we won't, we'll wait till the end of your talk to have our discussion to answer any questions that there may be. Yoav, would you be so kind as to allow Tanya to share her screen without making her host? I believe you can do that from the share screen and the options. It'll just make life easier for her so that we can manage any issues while she's giving the talk.
Well, sure.
I think you have it. I think you've done it. Have you not?
If I want to share screen now, host disabled participant. Well, you're the host now, so maybe you have these options.
Yep, I'll take care of that right now for Tanya, then no problem. All participants can share. One participant can share at a time. All right, Tanya, you want to check if you can share?
Is that better?
Yeah.
And let's see if we see full screen. Perfect.
What do you see there?
Now we see the presenter view.
We see the presenter view. We can see your note.
Now it's okay.
Yep, perfect.
Okay. I think it's because I'm just naturally connected to two screens, but I have no notes anyway.
But now it looks fantastic. Looks good.
Okay, all right.
So let's remove the share screen for one moment, and just so that I'll stop sharing here. Are you able to stop sharing for a moment?
Oh yeah.
Did you want to run through the slides?
No, I just can't find normally it just pops up here, but you can automatically disable me from sharing. Usually there's a thing that pops up here that says stop share, but it's just not coming up.
Done it for you.
I'll be right back. I'm just gonna have a cup of tea and
Go for it. Go for it.
טוב, חברים, יש לנו כבר 20 איש, אנחנו נחכה עוד כמה דקות למאחרים. דוקטור מימוני הביא לנו אורחת מאוד מיוחדת. בינתיים אני יודע לכם כרגיל על כל ההפניות, היה לנו מבול של הפניות החודש וחודש שעבר, אז תודה רבה. ונקווה לשמוע פידבקים גם מאנשים שאם חוזרים אליכם, פידבקים אני מקווה טובים, אבל גם אם יש אחרים, אתם מוזמנים לשלוח לנו. או אם יש איזו שאלה, אז יש לכם את המספרים שלנו בוואטסאפ, תרגישו חופשי, או בפורום או בפרטי, אנחנו לשירותכם. עוד כמה דקות נתחיל.
And Michael, do all the ophthalmologists in Israel, everyone operates, or are there lots of medical ophthalmologists, or I'm not sure how Israel is structured?
That's a good question. All ophthalmologists throughout training are supposed to finish their training so that they are equipped, with the basic capabilities such as cataract surgery. And I would say a high proportion of ophthalmologists are surgical. But we obviously do have general ophthalmologists and subspecialties which are non-surgical, but I would say that a larger portion of your audience today will be surgical.
Okay.
So I
think I had a few topics, and I had a few topics, and I was like, oh, dry eye clinic, maybe they're like a lot more medical topics. So I pivoted at the last minute.
I mean, it'll be great. Whatever you have ready for us, it'll be fantastic. They'll all enjoy it, whether they're medical, surgical, in residency, faculty, or more community-based. Whatever you have, it'll be fantastic.
Okay.
So Yoav, we'll give it one more minute.
Yeah.
All right.
I see that more people are joining. Yeah, Michael, I think we're good to go.
All right, so we'll begin now. I'm quite certain that more will join a bit later on. So today, I have the absolute pleasure of introducing Dr. Tanya Trinh, my senior co-fellow from the University of Toronto, who took over Greg Maloney's practice in Australia. I'm going to give a brief introduction about her. Which is quite partial, because once you get to know her, you'll understand how amazing she truly is. So Dr. Trinh is a fully qualified Rhinescope ophthalmologist specializing in cornea, cataract, and refractive surgery. She's also a fellow of the World College of Refractive Surgery and Vision Sciences. Dr. Trinh completed her Bachelor of Medicine and Bachelor of Surgery at the University of Queensland, where she was awarded a scholarship in medical leadership and the Australian Medical Association of Queensland Harold Plant Prize for Best All-Rounded Graduate. Dr. Trinh completed her ophthalmology specialist training under the Royal Australian and New Zealand College of Ophthalmologists in Queensland. She then embarked upon an advanced 2-year fellowship in cornea external disease and refractive surgery at the University of Toronto, where she developed extensive expertise in corneal transplantation, pterygium surgery, ocular surface regeneration, complex anterior segment surgery, and refractive surgery, including LASIK, PRK, and collagen cross-linking in the treatment of keratoconus. Dr. Trinh was awarded the position of Chief Fellow of the University of Toronto and subsequently received this prestigious Lim Memorial Prize for the subspecialty surgeon exemplifying best surgical and teaching skills. Dr. Trinh then undertook a research fellowship in laser cataract surgery, corneal transplantation, dry eye treatments, and ocular surface disease. Dr. Trinh has now been invited to join the team at Sydney Eye Hospital, Australia, as a staff specialist and is excited to be back home. She's published over 40 scientific journal articles in national and international journals, written book chapters on advanced corneal transplantation techniques and ocular surface disease, and is a regular presenter on the national and international conference circuits. She teaches medical students, residents, registrars, and fellows, is involved in the development of anterior segment curriculum teaching at the University of Toronto, and contributes regularly to community optometry education. She's also a clinical associate lecturer for the University of Queensland. She currently sits on the RANSCO Executive Committee of Women in Ophthalmology. She's also the head of the Refractive Surgery Terminology Committee for the Refractive Surgical Alliance. In 2022, she became the first Australian graduate of the Physician CEO program at the Northwestern University School of Business, Chicago. More importantly, she's one of my closest friends, and I'm absolutely blessed to have learned from her and to have her here with us today. Today, she will be giving a talk with us about surgical temporary ocular discomfort syndrome, which plagues many patients. And I can't wait to hear her talk. Stage is yours, Tanya.
Hi, thank you so much for the extremely kind invitation to speak with you all. All of the Israeli fellows that I worked with hold a very special place in my heart, and I had not learned a lot about Israeli culture and all of the beautiful things that your people represent. And I had the honor and privilege of working with Dr. Mamouni, and honestly learned so much from his skill and expertise. And you're very, very lucky to have him as part of your dry eye clinic and as part of your local world there. So thank you very much for the honor and invitation. I thought I would, given the name of your group, I thought that I would share a presentation on surgical temporary ocular discomfort syndrome, or STODS for short. And I wanted to introduce this term as part of a paradigm shift, at least for me, and what I foresee will wave through for those of you that are involved in refractive surgery or even cataract surgery, whether it's, or lens replacement, I should say, whether that's at the level of cataract or at the level of refractive lens exchange. And the importance of this change in nomenclature reflects a change in the way we think about what we are calling currently, and probably a little bit cavalier about it, dry eyes after LASIK. And I'm sure at your dry eye clinic that represents a not insignificant proportion of your patients. So the term has been chosen very carefully with a committee that I'll highlight later in the talk, but it was really chosen to reflect its surgical nature, that it is something that is induced by some sort of intervention, that it is temporary because it focuses on the healing aspect that is involved with this syndrome. It is ocular discomfort to validate what the patient is experiencing and not to just simply brush it off, because this is an enormous source of patient dissatisfaction. And really our philosophy is that if you are looking after patients and performing these sorts of procedures, you really ought to be well equipped with treating what comes and supporting the patients through that healing period afterwards. And I think your dry eye clinic is really well placed to be able to support patients through that process and have some sort of diversion pathway that your patients can access benefits from. So with our refractive surgery proportion, when we look at the statistics, about 25% of the European population, which is closer to your part of the world than mine, about 25% of that is myopic. And no, sorry, 30% of that is myopic, and about 25% of those patients of that population are hyperopic. So it's a not insignificant proportion of the population undergoing some sort of correction for refractive error. And a lot of patients will start at the level of contact lenses, and it's a fantastic option for a non-surgical, reversible way of correcting refractive error. But it's not without its complications. So a significant amount of patients will experience discomfort, particularly with increasing periods of contact lens wear. And I often say to patients who come for a refractive review or dry eye review is that, if you are wearing contact lenses, you need to think of it like you've been allocated 100 hours in your life that you can wear contact lenses, and you can't just burn through that, but in your first few decades. So there is rest periods, and allowing the eye to come to normality in between contact lens wear is really important for the health of your eye. But the dry eye symptoms are not an insignificant part of why people want to get out of contact lenses. And arguably, you could think of refractive surgery as being a cure from the dry eye that is being induced from contact lenses. Not only that, we have corneal infiltrates that can occur, and I'm sure you're well versed in treating these. GPC can be a real issue in a certain proportion of patients, and warpage syndromes that and I use that term quite specifically in that that with the types of contact lens wearers, particularly with ortho-Ks, if that is a procedure or a therapeutic intervention available in your country, that these patients often have quite distorted corneas simply from the act of having a piece of plastic on their cornea alone. But not only that, they can suffer from quite serious complications, so corneal neovascularization from our long-term contact lens wearers. They can suffer abrasions. Repeated episodes can lead to corneal haze, and of course, the dreaded infectious keratitis. And when we talk about the safety of various different interventions for refractive surgery, there's not a single moment in my public clinic that I don't have a patient with infectious keratitis related to contact lenses, but it's extremely rare that I'll have a patient with refractive surgery related complications. It is simply just not that common. Something to the slides here. Okay, so when we think about refractive surgery and how we've actually even gotten to this point, we need to think about how this all evolved. And when we look at PRK, we, in the early days, it was really quite painful. We were using an argon excimer laser. There was a lot of heat induced in those procedures. But now, thankfully, with the advances in PRK, the patients are going home and not having such a miserable experience. And the aftermath of their healing period is not as traumatic. When we moved to microkeratome LASIK, the flaps that were being cut by these blades were much deeper, much wider. They were much thicker flaps. We were trying to get really wide optical zones, and with even some surgeons extending the cut of the blade right through to the limbus. And you can imagine that distorts a lot of the corneal nerve anatomy that runs through the very sectors that we run the blade through. So the onset of femto LASIK was then a huge game changer, and the advancements in this area was laser pulses were becoming increasingly short with tighter spacing. The spacing is now timed in terms of where the spots lay on the cornea, so you have a reduction in the thermal pulsations that spread through the cornea. So there's a lot less inflammation with that dissipation in time of the energy spots. But we still have limitations. It will still cause postoperative inflammation. And the patients come in afterwards experiencing dry eye-like symptoms to the point where it's now a routine part of our protocol to offer preservative-free tears as an absolute minimum in complementation to the other antibiotics and anti-inflammatories and steroids that we use. But there's also a subset of patients that are more severe. They suffer for a longer period of time. And this has an enormous effect on their quality of life. And also from your surgical point of view, can be incredibly frustrating for the surgeon, because we don't feel that we have a great armamentarium for addressing the issues that arise after these interventions. And when we consider that, LASIK is one of the, if not the most highly studied medical procedure we have on the human body, there really needs to be probably a proportional amount of investigation in how we support these patients in this area. So your classic dry eye examination, and it varies a lot around the world, but most dry eye places will look at tear breakup time, Schirmer's testing, tear film osmolarity, fluorescein testing, lissamine green, which is probably not as common performed around the world, meibomian secretion scoring, and then there are a number of other modalities which allow you to objectively and look at the quality of the meibomian gland structure and anatomy, and correlating that with the tear film and tear film secretions. And the frustrating thing about all of this is that the objective signs don't always correlate, as you know, with the subjective dry eye symptoms, and that can be incredibly frustrating because we are not really able to use this as a measure or a bar for measuring a patient's initial status and also measuring their progress. And so the conversation really has now turned to, is there anything objective that we can quantify and correlate with post-refractive dry eye symptoms? And this is really looking at the era of tear film-based biomarkers. It really heralds a new era in dry eye diagnostics. It's, for one thing, it's really easily accessible, and the tear film contains a lot of parameters which reflects pathophysiological changes. The Schirmer strips we use, we normally throw away, but they actually are an enormous source of information and can be easily used then to obtain analytical samples with minimal intervention to the patient and no change to your usual workup as well. And we know that the protein concentrations contained within the tear film can dramatically alter during the natural course of diseases, or because of any surgical interventions we might inflict on the eye surface. And when we're looking at the biomarkers, it's a tricky field because there's over 1,000 proteins that you can look at in the field of tear film proteinomics. We can look at tumor necrosis factor alpha, the interleukins in the inflammatory pathways, IL-6, 8, and 17, which are common ones that we evaluate in your dry eye evaluation. MMP9, as you know, is probably our most famous, I guess, or well-known tear film biomarker that we measure. And that's actually a gelatinase produced in the corneal epithelium, which then becomes activated in the tear film, which is then measured. But interestingly, there's also pain associated tear film proteinomics that we can look at. So nerve growth factor is a factor which is increasingly being looked at as an indicator of corneal nerve damage. And calcitonin gene-related peptide also appears to be specifically involved in corneal pain or nociception, as well as dry eye symptoms. And there's an enormous amount of attention that's being turned to these proteins, and it's, it is so early in this field of study that we're not really sure whether it's the upregulation or the downregulation really that is definitively associated with corneal pain and dry eye symptoms. So at least when the group that I lead looking at how we should call this entity and whether there's any, we really wanted to look at an evidence-based way of ascertaining whether this is entirely a separate entity or whether this is exactly the same and we should be calling it dry eyes. And we wanted to look at the evidence. And I really wanted to draw attention to this study and the work of Sufi Taneri and his PhD colleague, Dr. Teresa Tsai, for looking at this paper that was published last year, which I'm going to go through and dissect. And really most of this talk is really credited to their work. And for me, it really opened up a new, as I spoke about in the beginning, a paradigm shift in the way we think about these symptoms after femto LASIK. And it's not as simple as calling it just dry eye after LASIK. And we probably should be using the correct nomenclature for this, because it means that if you're not giving it its due recognition, you can't actually target the actual thing that's going on. And the questions that they sought to answer is, what is the impact of femtoLASIK on dry eye symptoms and the biomarkers? Does femtoLASIK actually trigger pain markers in tear fluid? And can we separate these, analyze them, look at their quantification, and look at whether they correlate with dry eye symptoms reported by patients? And are there any baseline parameters that might give hints to the development of postoperative symptoms so that we can prophylactically either treat patients or select them based and risk stratify them and counsel them appropriately? So when you look at their study design of this specific paper, which now they've gone to replicate in SMILE patients, so they looked at hyperopic femtoLASIK. It was a small group of patients with a slightly male preponderance, the age of 37, which surprisingly is the average age of the refractive surgery patient worldwide. They looked at patients preoperatively, and then after LASIK, they looked at them at day 5 and day 10, and their regime postoperatively is to have 10 days of unpreserved ofloxacin and dexamethasone, as well as some artificial tears afterwards, and then looked at the patients measured at day 5, 10, and 90, and then used those Schirmer strips to undergo ELISA proteomics studies to see if they could ascertain some of these inflammatory markers in the tear film and also the nociceptive elements in the tear film. And they also supplemented these with a whole host of dry eye examinations, which obviously is a little bit exhaustive for the patient. But it was useful because the OSD in particular, we look at then the correlations between the subsections of this examination and what happened with the proteomics here. So I'm not going to butcher the efforts of their study, but I'll just attempt to summarize their key findings. What they found was there wasn't really a statistically significant difference in the Schirmer testing at pre-op 5 days and 90 days. There subsequently also wasn't that much difference in fluorescein staining, but there was a significant difference in lissamine green staining, and this was sustained right through to 90 days post-op. When they looked at vision-related functions, so for those that are not using the OSD regularly, it's quite a useful and validated tool for looking at vision-related symptoms and ocular symptoms related to dry eye. But the actual questionnaire itself is divided into 3 separate functions. What are the vision-related symptoms, and then what are the ocular symptoms that they're suffering from, and also then what are their environmental triggers of moodiness, humidity, and might have their place. And look at femtoLASIK, they found that there was a significant elevation after 5 days in the OSD score, which then did normalize at 90 days. This was statistically significant. But when they looked at the sub portions of the OSD score, and if I flick back, it was specifically this part of the OSD score that was actually driving the increase in the OSD scores at this 5-day mark. And so that's significant. And when they looked at vision-related components of that and of the OSD score, and then correlated that with the decline after at the different time points, they found that there was not only a statistical significantly increased aspect at day 5, that vision-related functional decline was then that recovered by day 90 was also statistically significant when you looked at that vision-related proportion. When they looked at the tear film biomarkers of inflammatory markers at MMP9, they didn't find that there was a significant alteration. In fact, it decreased, and one could hypothesize many reasons why, particularly because they're using the first 10 days of eye drops postoperatively. And when they looked at interleukin 1 beta and also interleukin 8, there were also no statistically significant cytokine alterations to go with that. So that throws things a little bit out of the picture from a dry eye point of view, because these are classically some of the markers that we would look at for your classic dry eye patient. When they look at the nociceptive or the tear film pain biomarkers, there wasn't really a huge difference in GF levels. But when they looked at the calcitonin gene-related protein levels, they noticed a significant down regulation after 5 days. So in summary, they noticed an increased OSDI score day 5, a higher lissamine green score, which was at day 5 and then continued right through to 90 days and also increased. No significant changes in cytokines and a significant calcitonin gene-related protein downregulation at day 5. And so with that, one could look and consider that with LASIK, it induces your dry eye-like symptoms, but not necessarily your dry eye-like signs. And so it makes us question, is this really discomfort related to the procedure rather than true dry eye syndrome in itself? And I know it sounds like it's semantics, but it's actually really important. The same group then looked at whether they could replicate this with other surgical interventions on the cornea and looked at SMILE patients. This is unpublished data from the same group. And they added TNF, tumor necrosis factor alpha and interleukin-6 in this study, but basically, looked at the study in quite a similar way. 35 samples in this group, so a slightly larger study, lower mean age, a fairly even distribution between male and female genders, but an identical proportion of, an identical use of postoperative treatment and identical time points as well. So I won't go through all of the components of their study again, but very similarly, they looked and found an increased OSDI score at day 5, and also the same proportion of the vision-related function is really what's driving the elevation in OSDI scores. They again found a higher lissamine green staining at 90 days. And interestingly, this time when they looked at the subcategories of OSDI, they did find a correlation between OSDI scores and their vision-related function and lissamine green at day 90, and also found a significant correlation between MMP9 and calcitonin gene-related protein between day 5 and 90. Now, not so significantly, they noticed that there was a significant downregulation in interleukin-6 to almost undetectable levels in that early postoperative period. So again, they found that SMILE, which is an arguably less invasive procedure to the corneal surface, induces, again, dry eye-like symptoms, but not necessarily the same signs that we would associate with dry eye syndrome, and cause us to ask, is this discomfort? And, one of the caveats of both studies is, could it have been the antibiotics we placed? What about the preservatives involved with this, although they used unpreserved in this scenario? Could it have been the steroids or the artificial tears that we use for discomfort, which would explain the MMP downregulation or absence of IL-6 seen in these patients? So when we're looking at this, they also looked at other different studies and looked at, are we really describing the same entity? And when we look at this study, looking at evaluation of dry eye after refractive surgery, looking at specifically meibomian gland status, this study also found an upregulation of your total OSDI score at the 1 month mark, which then again returned back to baseline at 3 months. And they also noted significantly higher vision-related scores again in the OSDI, with the highest meibomian gland dysfunction after 1 month. And that lower component in the OSDI score, when you're looking at air conditioning, humidity, and windy conditions, this upregulated in this group only after 3 months, which was quite interesting. Now, this is in contrast when you look at the International Task Force guidelines. When you're looking at classic dry eye disease, really what you should see in the OSDI score is all 3 parameters of the OSDI questionnaire really should be elevated. So it shouldn't just be one section that you're looking at. They should all worsen with increasing severity levels. And so the combination of amalgamating these studies together suggests that maybe these symptoms are not actually identical to classic dry eye disease. And does this mean we need a different treatment and diagnostics due to the different etiology of these? Now, the caveats of these studies in both of these, published and unpublished, that it's a small study. They only looked at 2 time points really after the of these patients. There wasn't a control group, so it would be good to know what happens to normal eyes when you just use the unpreserved tears and whether that has any influence in itself of the medication alone without the surgical intervention. There wasn't any paired eye analysis carried through to see whether there is any other additional influences within patients. And when we look at the field of tear film proteomics, it's enormous. It's like, which of those 1,000 proteins are we even studying the right ones? And what happens, and sorry, I've already alluded to what happens with normalized with the same post-op protocol. So the conclusions here is that subjective symptoms experienced by our patients are very similar to dry eye, detected via OSD in a specific subproportion of that score, but the alterations in objective signs are not observed. It means that the subjective symptoms are not specific for dry eyes, especially not after surgical intervention, and that the tear film deficiencies overlap with irritation symptoms caused by surgical wound healing, which is the same thing that we observe after cataract surgery, which is another group that could be studied to see if they are actually, now these are obviously smaller wounds, but to see if the same parameters elevate. And it may be more appropriate to avoid the LASIK-induced dry eye, and that has important medical legal connotations. And that's another reason why this is so important, and use LASIK-induced discomfort and emphasize the healing and temporary nature of this, rather than classic dry eye, which is something you can manage, but usually something you'll have forever. Examinations of tear film proteins really only showed a significant downregulation of CGRP after femto LASIK, and we need to look at the role and, should we be using these medications for a little bit longer, and what does that do to these levels? And, whether targeting these pain markers, is this something that we can pharmacologically target preoperatively? Some people are using antibiotics and steroids in the preoperative phase before surgical intervention, or whether we use this for a longer period afterwards, or whether we can even develop pharmacological mechanisms to target these as a separate entity and maybe even an additional eye drop in its own. So in conclusion, this really opens up an enormous field of study in terms of whether we can get a better understanding of the healing processes after refractive surgery, and that a detailed analysis of which pain markers to even study after this is really lacking. We don't have a good grasp on this yet. Can we identify biomarkers to detect patients at risk of developing these syndromes and look at different therapeutic options afterwards? So when we look at the therapeutic surgery committee, I'm lucky to work with a really amazing group of individuals who took the time to think about what otherwise would be a very dry and painful topic, because no surgeon likes to know that they are contributing or causing any sort of discomfort in their patient. But if we don't look at this really important study, it has the potential to really bastardize this area if we're not careful about knowing how to manage it. And just to look at that rationale and revisit that again, really we're looking at the way that this accurately is differentiated from dry eye, and placing an emphasis on that healing, temporary nature of this condition. It just validated it without alienating your patient and driving them away. And I think, again, having dry eye clinics such as yours is a really fantastic option for surgeons to send patients. It avoids the fact that it's iatrogenic or induced, and that's important medico-legally, and it emphasizes this is a normal part of healing and something that we can very much manage. We also considered and rejected a number of other terms, specifically because we didn't feel that it was either very scary for the patient and didn't really place enough emphasis on the temporary and healing nature of the procedure. And also for its avoidance of any manipulation medico-legally as well. So in summary, STODS, or surgical temporary ocular dysfunction syndrome, or discomfort syndrome, is really described that transient irritation. It is experienced by the patient as a normal process of healing after any surgical intervention of the eye. This is not just related to refractive surgery, but also to cataract surgery, or even in your post-transplant patients. It should not necessarily be confused with dry eye syndrome, although we appreciate it is really easy to call it dry eyes. And we appreciate that the sensation is very similar for the patient and that it's not unique. It is actually quite a common and should be an expected part of the healing process after patients. And it's really important that you counsel your patients appropriately to expect that and to manage that expectantly. So that's just that slide again. And thank you very much for your time.
Thank you very much, Tanya, for this great talk. We have a few questions. I want to ask first, there is, of course, after surgery, after every surgery, there is the nociceptive pain. You have tissue damage, and there's the neuropathic pain. Would you consider this STODS continuum in which the end is irreversible corneal neuralgia? And why do some people present with irreversible pain while most of the other people it's reversible after a few months?
That's a really great question. It's something that we don't fully or completely understand, and Annette Gaylor's group is doing a lot of work in Bascom Palmer to elucidate whether there are central or peripheral processes to that nociceptive process in corneal neuralgia. There is increasing suggestion that these patients may also have other complex regional pain syndromes, and it's frustrating because we don't have a definitive explanation for these. We know that the improvements in refractive surgery are reducing the burden that we place on the cornea in terms of disruption of that corneal innervation. We know that there are a proportion of studies that suggest that most of these changes normalize after about 9 to 12 months, but there is a subset of proportion of patients who don't totally have normal corneal nerve anatomy even after that time. When I screen patients for refractive surgery, I have now since added another step because of the recognition, and the clinic that I work at before my time actually has one of these patients who became acutely suicidal after having one of these interventions. I now do routinely screen for patients with a history of chronic pain, depression, anxiety, things like fibromyalgia, chronic back pain. And I specifically ask patients about it. And the way that I phrase it to patients is that we don't have a great explanation for why you have chronic pain in other areas of your body. There is a suggestion that there may be an association between underlying mental health conditions and a propensity to experience pain after otherwise surgically very routine and very normal interventions. I do think it's really important for the clinician to acknowledge that from the start, and to let the patient know that the vast majority of patients go through these procedures without having a permanent, innervation deficit and pain. We don't have a good way of screening who they're going to be, and we don't have great ways of treating it afterwards.
Would you opt for surface ablation in patients with fibromyalgia rather than LASIK?
You can, but it's not 100% guarantee. So yes, I would lean towards a more surface-based procedure, but even PRK alone can be really discomfort. There's not particularly with trans-epi PRK, there is a lot more heat dissipating through the cornea with this. I'd certainly see more haze with these patients than with traditional alcohol-related techniques. That's not to say that that's going to be your fail-safe. So I will counsel them more towards a less invasive, less, LASIK-based procedure, but it doesn't change the way I counsel the patient beforehand, because it's not a guarantee that they're not going to get this condition afterwards. Yeah. It's a great question, though, and I wish I had a complete answer for you. It's a huge area of study and so frustrating for us all.
Margarita, I believe you had a question you wanted to ask as well.
Thank you. It was really fascinating. You described there is a downregulation of pain markers, yet the patients describe increased discomfort. How does it go together?
Yes. So this is really early in that field. So all we know is that these are released at the time of corneal damage. So when you're doing the procedure, really shouldn't call it damage, but we are changing the anatomy when we're cutting through that nerve. And we know that these are released during that time. One of the caveats of that study is that when you're putting in your artificial steroids, some groups also put in non-steroidal anti-inflammatories, whether that changes the downregulation in that early postoperative period for 10 days. So that is a confounding factor. And that study did not have a control group to look at whether the same sorts of changes would occur in patients that, have not had any treatment at all. So that's a little bit difficult to tease out. But even that group, even Sufi's group, is looking at what this actually means. We don't know that the pain pathway is so complex that it's not necessarily upregulation of one, therefore it's not a linear pathway. We know that the increase in one paradoxically can mean the downregulation of other factors that sort of get triggered in the process, and that pain pathway is not totally elucidated. So it's a really interesting, it's a huge area of study that their group is looking at now.
Thank you.
Thank you.
Bell asked about the autologous serum, how efficient
Yes,
is
exactly.
Itamar, you wanna phrase your question?
Yeah, so I already asked about some of the things that Professor Nahum asked about. I just wanted to know if you have a place for the autologous serum tears in those specific sensitive patients who does come with some kind of history of excessive pain, fibromyalgia, and things of that nature. And do you have any other kind of treatment options for those patients specifically?
Yeah, sure. You're talking about dry eye patients in general, or specifically after?
Specifically post LASIK.
Post LASIK.
Mm-hmm.
I have not yet had a patient that I've required to put on serum tears because they have had an intervention that I've performed personally. I have treated patients that have come from elsewhere that have had refractive surgery that have gone on later on, but usually it tends to have been like quite a fair way on, like they've had LASIK in their 20s and 30s, and then they come back as a middle-aged female and they've blown into something else. So it's not necessarily directly related. In terms of where serum tears, I actually quite rapidly go to serum tears. Partly that is driven by the fact that patients often, when you talk about medicamentosa, patients are putting so much artificial everything on their eyes that it is one thing in their arsenal that they can try that came from their body that we didn't add anything to, that you can put on with I've only ever had one patient that's actually been irritated by their own serum, which I found quite strange because it's literally made from themselves. And I don't know if you have had that.
I've had a case. We should write that up. I still can't explain it either. I've also had one patient which would have this weird allergic reaction from their own serum, which I couldn't explain. We should write that up.
I had a patient with GVHD who couldn't stand his own serum, but was good with allergenic serum.
Really?
Yeah. So they were okay with allergenate, but not with autologous.
That is so interesting. I had the same thing, Yoav. We switched to allergenic and it worked, but they could not tolerate their own serum.
So, oh, sorry, one of my light bulbs just blew. That's really good. So just to finish up that conversation, so with autologous serum, the way I pitch it to patients, we don't actually know what is the magic ingredient in autologous serum that makes patients feel so good. I'm really honest about that because whether it's the cocktail, whether it's the balance of growth factors and the anti-inflammatories contained within serum, it is such a complex mixture. What I do tell patients is that it's literally made from the cells with nothing that we've added to it. It is likely to be very well tolerated without inducing any other symptoms, except for that one patient. And conveniently for us, our Red Cross blood service makes it for free. So it is, the patient's financial burden from using lefidograst and cyclosporin, sometimes tacrolimus, steroids on occasion, and, artificial tears, that financial burden is not insignificant. And so to have something like, it might not be financially significant, but it is logistically significant because you have to keep it in the freezer and the bits that you're not using have to be frozen and you have to defrost the bit afterwards. So that's from a patient load and impact on their life is quite significant. But I freely use serum tears. I do find a lot of patients benefit a lot from it. My Sjogren's patients love it. We have a product called Nova Tears here in Australia, which is also quite helpful, which is an oil. It's really just based on the oil. Can't remember what the active ingredient, the name escapes me. Nova Tears. Anyway, if you don't have it, you should definitely look into it, because it's the only thing other than catianorm that focuses on replacing that pure lipid layer. And I use it synergistically with your preservative-free artificial tears. Platelet-rich plasma is something I don't really have access to readily in Australia without it being supremely expensive. My patients cannot afford $1,000 per batch to have it made. Maybe one center makes it. I would love to have it available, but we just don't. But yes, I do find it quite useful in my armamentarium for treating dry eye patients.
I 100% agree with you. I go very fast autologous serum in general and ocular surface disease patients. And, you know, specifically giving the paper you just introduced us and the terminology you just introduced us, it does not seem as though it's inflammatory mediated, at least from the markers that they checked. So then you suddenly realize, wait, cyclosporin 0.05% or lifitegrast or tacrolimus, they're less likely to respond to those treatments if we're not looking at inflammatory mediated disease, right? Whereas autologous, like you said, it's kind of like a special potion, which we don't really know how it works, but it just does seem to work. I do tell these patients post LASIK, whether they arrive 3 months or 3 years afterwards, that it's going to take a really long time and to be patient with the autologous serum. And I was kind of wondering, given this new terminology, which is very reassuring for these patients, for our patients, at what point, it's kind of a continuum to Yoav's question, Itamar's question, at what point do we shift from calling it, temporary ocular discomfort, and we call it, the name we kind of try to avoid, corneal neuralgia? Like, would you give it like a year, 2 years? When would you say, okay, this is no longer this temporary discomfort? We have a patient, a year or two, pain without stain, etc. When does this become corneal neuralgia?
Yeah, that's a great question. That study that they looked at really only looked at day 90. I do believe that they are going to publish or are looking at their 1-year results. So it'll be really interesting to see, if I heard correctly, where those pain markers go. I think it's important to distinguish between, so when we use the term surgical temporary ocular discomfort syndrome, it is not just, let's be clear, it is not just the dry eye-like symptoms that they're getting. The pain is also another component, and they don't necessarily have to come together. So you can just have the dry eye-related discomfort without it being painful. So I separate that, and it is a general term, but you do need to be very clear about the fact that the pain, you need to separate your pain patients and general pain patients from your ocular discomfort, because you cannot lump them together. And if you're telling your ocular discomfort patients that it's a neuralgia and it's pain, you kind of probably are opening yourself up to medical legal entities in itself. And that's why it's this area of study, although it seems quite dry, is really important, because if they are truly actually separate, then we have another subcategory that perhaps we could target and help these patients with, without opening yourself up to, a lot of, telling a patient with dry eye symptoms that they have a neuralgia. Technically, I probably wouldn't go so far as to call it that unless they genuinely have pain. For me, that is a core difference.
Good point.
Yeah, exactly. I have had the pain pathways. It's as frustrating in the neuro world, where they're looking with migraine and headache or chronic pain of the back. We don't, yes, there's impingement of certain structures, but aside from that, it is incredibly frustrating to treat. And even they don't know what they're targeting, and they're literally in the pain, spectrum in terms of dealing with that every day. And we stand a lot to learn from those other specialties, but I think until you definitely know that that's pain, I would actually wait quite a long time before calling it an actual neuralgia, and make sure that they're actually in pain. And I ask patients, is this actually discomfort that is just causing a lot of annoyance to you? or is it actually painful? Because it changes the way I treat the patient. Then I'll start looking at things like amitriptyline, gabapentin, Lyrica, those sorts of medications for actual pain. And I use a pain specialist, or at least the very least a general practitioner. And I tell them that it's not because I think you're depressed that I'm using these antidepressants to treat your pain. It is because these medications have some role in modulating your pain pathways. It's not because I think you have a mental illness underlying. It's really important that you're not telling the patient that they're crazy.
Yes.
Dr. Tanya, I have two small questions. One is that when we see LASIK or other refractive surgery patients, they're young patients, they're healthy, they come and they want to get their surgery fast. They don't have time to optimize their ocular surface. But with cataract patients, usually they are more patient, and many of them has meibomian gland disease or other dry eye symptoms. Would it be of benefit to optimize, and not yet another reason to optimize the ocular surface before cataract surgery in order to avoid this syndrome? And another question, I always wondered, why do some patients have filamentary keratopathy while others don't?
Wow, that's like two totally random questions, as in not related to each other. Okay, so the first question in terms of cataract surgery and optimization. So this is just me speaking very, very off the cuff here. I really think it's important to optimize with patients. All of my patients for their preoperative testing. So after they see me, if we decide you're going to go have, they don't actually have their biometry done with me on that day, we will make them go home and do at least 4 days of preservative-free sustain and 2 days of FML before they come in for their biometry. And because we're a refractive-ish based clinic for cataract surgery and people come to us for their results, we tell patients freely that we are as invested in their outcome as they are, and that we are as invested in the workup as they need to be with us. And so if my diagnosticians find that their tear film is not great and the scans are crap, we will delay their surgery and we will make them do their homework. And we will tell them that we're not going to move forward until we're happy with the scans. And the patients are generally, we're lucky to work in a particular area where patients are fairly cognizant of that. But there are some surgeons which I think have like 4 6-month waiting lists, and I've only been back for 2 years. I do not have the luxury of having such a long wait list. But they're in those clinics, they have whole dry eye contingents, a whole package and plan that they put patients on. And whether that is, again, speaking off the cuff, whether that is financially driven as another way to optimize patients and get patients through, or, it is actually probably a good thing to do. But a lot of patients kind of just want to have it in and out. And there is enormous competition and pressure, particularly between refractive centers to this whole thing of get your surgery done the same day as your consult, and, no downtime, and shorten your consultation, and whether we do a full cyclopedia refraction on every patient or not. I think we have to be really careful about abbreviating the workup for patients, because if the patient feels that it's a simply walk-in, walk-out procedure, they are not going to understand the complexities of what it took to them to get to that point of surgery, and much less understanding what it's going to take to get them out of something that they fall into afterwards. I personally think that the more seriously you take it beforehand, the more seriously they are likely to take it afterwards, and also view it as this is not a simple procedure. This is real surgery. We just make it as pleasant as we can for you. That doesn't mean that it's without its own caveats. I don't know if anyone else has anything to say about that. That's partially.
Thank you very much.
With the filaments.
The filament.
Yes.
Doctor, I have another small questions.
Yeah.
Do you have some kind of screening tools during the pre-operation examination? I don't know, for testing for an abnormal corneal sensation, some kind of an abnormal sensation to pain on the skin around the eye that will give you some clue whether this patient will eventually develop this kind of excessive pain tolerance? or less sensitive tolerance?
Other than the history that I take, I don't routinely test. It's a great way to, but I don't think, like, most patients are going to be, like, the patients are going to be fairly normal to start with. So their sensation is likely to be normal, even if I was to use like the Cochet-Bonnet off, beforehand. I think it would be interesting. You'd have to do it, the last thing in your refractive workup, so the corneal surface remains untouched. Michael, maybe that's a great area of study for you and your research team to look at. I don't know if it would necessarily...
We can just slap the patient and then see how hard they squeeze.
Yeah, that's right.
That'll be a great way of testing to see how sensitive they are.
I mean, part of the reason why I put it in the history is that it reminds me to have that conversation with patients if it's in that workup, because if you don't specifically ask for it and you rely on it being like, I'm sure everyone here, that the actual consent form, if you went through it properly, would probably take you half an hour at least. And we abbreviate it to less than a few minutes. And then you look back and the patient develops something, you look back over your consent form, you're like, it is there, but did I spend the whole 10-15 minute conversation it is around that topic alone? Probably not, to be honest. And because it's just not practical, and the patient's unlikely to take that in with the enormous amount of information you give them at that consultation anyway. So apart from the history, in short answer to your question, no, I don't normally check corneal sensation. It's probably not a bad thing to do. I just don't routinely do it because most of the patients are going to be normal and most of the patients are going to be sensate. And I don't necessarily know that having a sensate cornea to start with, I don't even think with the Cochet-Bonnet, you can even tell if a patient's hypersensitive. I think you just tell whether it's sensitive or not, right?
My thought was about like instilling some kind of anesthesia drop. And if the pain goes away, it tells me something about it. If the pain stays after I instill the anesthesia, maybe he does have some kind of nerve abnormality. I don't know. That's what
you mean preoperatively?
Preoperatively.
Oh, if they had pain preoperatively, I would just not operate on them.
Mm-hmm.
I would really just say no, because I would like, and I tell them, you'll probably walk down the road and find a surgeon who will do that.
Yes.
But I can't predict that you're not going to have this pain. You already are in some way hypersensitive. If the patient genuinely has serious chronic pain issues, I will actually carve out a section of the consultation to talk to them about it. And I just say, look, it is super rare. I just have no idea who it's going to happen to. There are going to be heaps of patients with chronic pain who went and had refractive surgery and they were just fine. I just can't pick who that's going to be, But it's not, you have all seen those patients who we didn't really look at chronic fatigue, fibromyalgia and things like that very closely. Then they develop pain afterwards. And then you look at the history and you're like, oh, you're one of those patients. And that's terrible in itself, right? We shouldn't, we groan and moan about it, not because it's the patient, it's because we don't understand these conditions very well. That's a reflection of our own frustration, the limitations of our understanding in these areas. It is not actually the patient being annoying or, mal in some way. It just really reflects that we do not manage it very well. So your filamentary keratopathy, so I do go to using N-acetylcysteine fairly quickly. I find that patients usually have a course and they settle, and I can't necessarily predict when they're going to go back into mucus filaments again. Some patients just have this one episode and they're fine for years. Some of them need to be on N-acetylcysteine indefinitely. And it stinks when it goes on. So the management of all of the other factors of dry eye treatment need to be maintained during that period too. I can't actually remember what the crux of your question was with the filament.
Why do some patients get filaments and others don't?
And some don't.
Yeah, look, when I explain to patients about the tear film, because I'm trying to get them to use the oil drops 4 times daily in conjunction with the preservative-free artificial tears. And I tell them, like, we have treatment for 2 of the components of your tear film and not the third. Mucus drops don't exist. And I think of those mucus producing processes as simply an imbalance. You're either not producing enough aqueous or lipid, and so your dilution is wrong, or there is something that causes your proteins of your mucus proteins to coalesce in a manner that causes them to aggregate. And whatever is the sort of soapy factor, I guess, the surfactant that causes them to dissipate is out of balance. But I know if that's what I think the is going on there.
I agree with you 100%. We've got a series of, I think, 6 or 7 patients by now with nasty filamentary keratopathy that, despite acetylcysteine, it continued. And what actually helped them the most in the end was meibomian gland expression. And I think that kind of like intense repeated meibomian gland expressions, and I think that kind of reset their system and the imbalance which you were just mentioning. Hopefully we'll write that up as well at some point.
That's fantastic. So do you IPL them as well when you?
So you can definitely. I think that would definitely help as well. Specifically, these were patients that I saw at Rambam where I do not have an IPL. And so just the meibomian gland expression alone in itself was very helpful in kind of resetting the filamentary keratopathy in these persistent cases. So I definitely agree with you. There's some sort of balance either between the meibum and the aqueous. We often have that combined with autologous serum as well. Like I said, I mean, I use that in almost all these patients, but still for these persistent cases, what actually helped them was intense meibomian gland expression. And always they have like the nastiest of nastiest, the toothpaste coming out in these cases. So yeah.
I think maybe we had one patient with IPL with filamentary keratopathy, maybe one in our clinic. Yeah.
Yep.
Okay, I think it's about time to finish our presentation, right, Michael?
We're at 10 p.m. and Tanya probably has to go to work now at 7 a.m.
Have to get up. Thank you so much for joining us in this peculiar hour in Australia.
Oh, my pleasure. I'm so excited. I would love to come and visit your country. I've heard so many amazing things, and the food is amazing, apparently. So
yeah, and we don't have these weird giant spiders and sharks that you have in Australia.
I know. I have one in my bathroom at the moment.
A shark or a spider?
A spider.
All right.
So thank you again. Thank you so much.
Thank you so much
for your
honor
visit.
Thank you.
We really hope to meet you physically at some of these conferences that we have from time to time. Thank you again. Thank you everyone for listening. The presentation will be available in our YouTube channel as from tomorrow, probably. Thank you.
Great. Thank you so much. Thanks.
Bye-bye. Thank you.
Bye. Bye, Michael.
Bye, Tanya.
Bye. Bye, Margarita. Maybe we can talk this weekend for free. Okay. All right. See you.